let's jump right in. Welcome back. Today, we're stepping straight into the clinical courtroom. See, too often, a clinical lawyer spots a symptom and just jumps straight to an assumption, ordering broad treatments based on pure noise. But a truly great clinician? We need to act as the clinical judge, demanding a strict physiological audit to find the actual diagnostic signal. So let's look for the precise tipping points in 3 really complex physiological dilemmas. Here's our clinical docket for today's explainer: the clinical audit, the peritoneal fluid audit, the manometry waveform, mucosal versus luminal limits, and finally, avoiding the dumb mistakes. Let's get to it. Module 1, the peritoneal fluid audit, spontaneous bacterial peritonitis versus secondary peritonitis. Okay, picture this. You've got a cirrhotic patient presenting with a fever, shifting dullness, and diffuse abdominal pain. Now, the clinical lawyer immediately wants to blast them with broad-spectrum antibiotics, just assuming an infection. But the judge demands an audit. First up, we calculate the SAG, the serum ascites albumin gradient. You just subtract the ascites albumin from the serum albumin. If you get a score greater than 1.1, well, that establishes the baseline presence of portal hypertension, which completely sets the stage for SPP. But now we're facing a real 50-50 dilemma. Is this an isolated spontaneous bacterial peritonitis, or is it a secondary peritonitis from a surgical emergency like a perforated viscus? Well, SBP is typically a monomicrobial infection, usually from translocated enteric flora like E. coli. Secondary peritonitis, on the other hand, is a chaotic polymicrobial disaster. Because you've got multiple organisms rapidly consuming resources and literally destroying tissue, the acidic fluid is going to show a very low glucose level, typically under 50, and a highly elevated LDH. But for SBP, this single number is your true signal. When you perform a diagnostic paracentesis, an absolute neutrophil or PMN count of 250 cells per cubic millimeter or greater is generally diagnostic of spontaneous bacterial peritonitis. You really don't need a massive, complex array of tests here. You just need to isolate this specific cellular count. Which brings us to a critical, really urgent warning. This is the first major dumb mistake you absolutely have to avoid in the clinic. I mean, why not just wait for the acidic fluid culture results to come back so you can be 100% sure before hitting the patient with antibiotics? Because waiting for a culture is falling for diagnostic noise. Honestly, cultures take up to 48 hours to return. And worse, they can be falsely negative in up to 40% of SBP cases. 40%. Cirrhotic patients can decompensate incredibly fast. So the absolute crucial takeaway here is this. If that PMN count is 250 or greater, you must execute immediate empiric treatment. You hit them with a 3rd-generation cephalosporin, something like ceftriaxone, and, crucially, you administer intravenous albumin specifically on days 1 and 3. Why? To prevent a totally deadly complication known as hepatorenal syndrome. Moving on to Module 2, the manometry waveform, mechanical obstruction versus functional dysmotility. Let's move up to the esophagus and find the diagnostic dividing line for dysphagia. We have to figure out if a physical mass is actually blocking the tube, or if the tube's muscles are just refusing to work. The physical progression of the patient's symptoms, that's your tipping point. A mechanical obstruction, like an esophageal cancer or stricture, typically presents with dysphagia to solid foods first. As the lumen physically narrows over time, the patient eventually struggles with liquids. But in a functional dysmotility disorder, like achalasia or diffuse esophageal spasm, the dysphagia for both solids and liquids occurs simultaneously right from the onset, because the neuromuscular coordination itself is broken from the start. And we can brilliantly see the striking geometric difference on a barium swallow between those two functional disorders. We have achalasia, where the dilated esophagus sharply tapers down into a classic bird's beak narrowing at the lower esophageal sphincter. And then diffuse esophageal spasm reveals this chaotic corkscrew pattern caused by high-amplitude, simultaneous, non-peristaltic contractions. And fun fact, those contractions can actually mimic the intense chest pain of a literal heart attack. While the barium swallow gives us a fantastic visual, esophageal manometry is the absolute most accurate test. It provides the definitive functional geometry of achalasia. It proves a high resting lower esophageal sphincter pressure, a total failure of that sphincter to relax when the patient swallows, and it's all paired with a complete loss of peristalsis in the distal esophagus, which happens due to the degeneration of inhibitory neurons. So, looking at that unmistakable bird's beak on the barium swallow, is that alone enough to diagnose achalasia and send the patient straight to a surgical myotomy? Hold on, stop right there, because assuming the barium swallow is enough is our second disastrous, dumb mistake.
An upper endoscopy an EGD, is absolutely mandatory first. You must directly visualize the esophagus to rule out mechanical and structural disorders that can masquerade as a motility issue. We call this pseudo-achalasia, and it often happens when an adenocarcinoma right at the gastroesophageal junction mimics the exact motor pattern and tapering of primary achalasia. Trust me, missing a cancer because you completely trusted a functional scan is a catastrophic error.
Module 3. Mucosal versus luminal limits. Celiac disease versus chronic pancreatitis. For this one, we travel down to the intestines to dissect the structural pathway of malabsorption. When a patient presents with steatorrhea, weight loss, and nutritional deficiencies, we have to establish exactly where the kinetic failure lies. Is this celiac disease, where the actual wall of the intestine, the mucosal villi, is flattened and damaged by an autoimmune reaction to gluten? Or is it chronic pancreatitis, where the intestinal wall is perfectly fine, but the chemical tools, the digestive enzymes normally secreted into the lumen, are completely missing due to scarring of the pancreas? To find the specific signal here, we use the D-xylose test. D-xylose is a very simple carbohydrate. When ingested, this simple sugar doesn't require any pancreatic digestive enzymes to be broken down. It's ready to be absorbed directly by an intact intestinal mucosa. So it perfectly isolates the function of the intestinal wall. It's like testing the plumbing without worrying about the water quality. And this leads us to a beautifully binary outcome. If the D-xylose levels in the blood or urine are low, it confirms the intestinal lining is damaged, pointing straight to celiac disease. But if the D-xylose absorption is totally normal, it proves the mucosa works perfectly fine. That signals that the malabsorption is a luminal, digestive failure, pointing right to chronic pancreatitis. Now, let's say you suspect celiac disease based on the patient's history. The big question arises, should the patient start a gluten-free diet immediately just to see if their symptoms improve? Well, here lies our final dumb mistake. It's an incredibly common clinical trap that will literally ruin your entire diagnostic audit. The premature diet trap is super dangerous. The initial tests for celiac are serologic markers, like the anti-TTG IgA antibody, followed by the absolute gold standard, an intestinal biopsy. But if a patient stops eating gluten before these tests are performed, the autoimmune reaction stops, and the mucosal tissue actually heals. By removing the trigger too early, you destroy the exact evidence you need, the flattened villi and the antibodies, to secure a definitive diagnosis. The patient has to be on a gluten-containing diet for an accurate audit of the villus architecture. Section 5, Avoiding the Dumb Mistakes, a summary of pitfalls. Being a great clinician isn't just about memorizing textbook facts, right? It's about sequencing your tests correctly and knowing exactly what data to trust and what data to completely ignore. By prioritizing the true signal over the noise, you can avoid these 3 critical delays and diagnostic blind spots. For SBP, trust the PMN count over the slow, unreliable cultures. For achalasia, never trust a functional motility scan until you've used an EGD to rule out a mechanical cancer. And for celiac, please don't let a premature dietary intervention erase the mucosal evidence you desperately need for a gold standard biopsy. I want to leave you with this final thought to really challenge how you filter clinical information during your next patient audit. In an absolute sea of data, are you delaying life-saving action because you're waiting for perfectly neat but ultimately noisy test results? Keep your focus sharp, trust those physiological tipping points, and I'll catch you in the next explainer.